what would you say to those who want to understand what is functional cardiology or what is functional cardiometabolic medicine to you? How would you define that?
What it comes down to is the appreciation of a whole patient and recognizing that person as an entity. Functional medicine is not simply green pharmacy. It's not making a diagnosis in the traditional way. It is instead saying, what is the underlying process that's driving this?
Hi, I'm Dr. Michelle Leary. I'm host of the new Vida Vitality podcast. We're so excited to bring this to you. It's been in the works for multiple years. This is a way for our doctors, guests, people who are experts in their field to then bring real-time information on what they're reading, what they're talking to their patients about, what they're passionate about, and translate that information directly to you. I'm going to be doing a reintroduction of our guest today, Dr. Joseph Lamb, mainly because a few things have changed, very exciting things have changed since we initially interviewed him a few months back. So before I get to those announcements, I want to just give you some information about his bio. Dr. Lamb attended the Medical College of Virginia and attended the residency program at Presbyterian University of Pennsylvania. He then did a one-year cardiology fellowship at the University of Colorado. Dr. Lamb has over 35 years of clinical experience, 20 of which are clinical research. He is also the clinical medical director of Nature Sunshine, and I'm excited to announce that he is joining our practice at Vida Integrated Health. He will be actively seeing patients and being the current medical director, working closely with me as the functional medicine director. Very excited to have him on board. He's also part of the Consilience Partnership and has a paper that was recently published, a proposal to the whole clinical medicine in the noosphere. Welcome, Dr. Lamb. Can't wait for you guys to hear our conversation.
So the reason that I wanted for us to have this conversation is, number one, you've been such an important part of my career and my learnings, but just your background is very strong in cardiovascular and cardiometabolic medicine. And I'm wondering if we can just kind of get a smattering of what attracted you to this field. You did a year of fellowship in clinical cardiology.
Yeah, I think, my residency program at Presby, one of the Penn affiliates in Philadelphia, was really very cardiology heavy. It was actually interesting. Our chief of medicine and chief of cardiology, Dick Helfont, had a long-standing rivalry, antagonism with a guy named, I think, Mark Josephson. And Josephson ended up being chief of cardiology at the hospital of the University of Pennsylvania. And Dick Helfont took half the medicine department and went across the street to one of the affiliated hospitals. And instead of continuing to be a shared program, they made two programs. Mm-hmm. But cardiology was king in my residency program. And a lot of heart surgery was done on a regular basis. And cardiology was where the challenges lied. And also, while we had great attendings in pulmonary and GI and rheumatology, the cardiology attendings were truly king. Mm-hmm. And internal medicine residency is set up so that by early in your second year, you're already deciding where you're going to go interview. Mm-hmm. And if you're thinking about a fellowship, you're already applying in October, November of your second year. So you've done your internship, you're in your first year of residency, and you're applying for where you'll be going in about 18 months in terms of a subspecialty. And cardiology was interesting and challenging.
So you did this residency, you became infatuated essentially with the mystery with the eloquence of cardiology, and you decided to then pursue that to a fellowship. You did a year of 5 years, typically?
At that time, it would have been 3.
3. And talk to us about your decision to then pivot, go back to internal medicine.
So, yeah, it was interesting because through the course of the year, I started realizing that I wasn't taking care of people anymore. I was taking care of an organ, right? And and also I was broke that year. I had been able to moonlight when I was a third-year resident, and I wasn't moonlighting as when I was in my fellowship. And so going anywhere where there was a free lunch at lunchtime from a drug company, you went for a free lunch. And I had just rotated into Denver General Hospital, and they were having M&M conference, which is morbidity and mortality. And it's typically where one of the subspecialties presents a case, and usually it's about themselves, right? This is something where we could have done better and we could have learned more. And interestingly, the renal department, nephrology, was presenting a case where cardiology had messed up. And there is no one from cardiology in the room. Everyone got the message except me, and I went for the free lunch. And at the very end of it, one of the renal attendings was like, well, Dr. Lamb, you're the only one from cardiology brave enough or foolish enough to show up. And this was like March, right? Yeah, but she was sort of making a joke, right? Okay, yeah. And it was March of the year. And she said, what would you like to say about blah, 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 right? And there was no way to win, right? And I, without really thinking, I said, well, there's the heart and the extracardiac debris. You've got one heart, but you've got 2 lungs, certainly 2 kidneys, 2 legs, 2 arms, 2 eyes, even 2 guts. So really, as long as the heart was okay at the end of it, we did our job. And the rest of it's for you all to pick up. And people started laughing. The bell rang. I walked out of the room and went, oh my God, I wasn't joking. So I went back down the hall to the tiny little cubicle where we would read cath films. Because back in those days, the films were actually on like 16 millimeter film, right?
Oh, gosh.
They weren't digital. They were on film, and you would roll them back and forth.
Bringing us back.
Right. And I walked into the room, and there was a phone, and I dialed my family doctor in DC, and I was like, Frank, can I come home? And he's like, well, actually, we do have a place if you want to practice internal medicine. And 3 months later, my fellowship, I terminated it early, and I went back to Virginia, and I started practicing internal medicine. And a series of coincidences and people who I knew and people who I met led me to functional medicine and integrative medicine.
Yeah, that was going to be my next question is, you've been practicing functional medicine going on now 30 years, plus or minus?
I was introduced to the term functional medicine probably in 97 or so.
Okay, so close.
Yeah.
Close to. And you have not only taught functional medicine, you've written about functional medicine extensively.
Right.
You've practiced it with patients.
We have a paper we're about to submit to Lancet called The Conundrum of Medically Unexplained Symptoms.
Mm-hmm. So you've been really established yourself as an expert in this field. What would you say to those who want to understand what is functional cardiology or what is functional cardiometabolic medicine to you? How would you define that?
Well, I think what it comes down to is the appreciation of a whole patient and recognizing that person as an entity. And, that was part of what we wrote about in the paper, a proposal to hold the knowing, right? If you don't understand the existential questions that your patient understands their life by, it's very hard to communicate with them in a way that engages them in meaningful lifestyle change.
As an example?
We have people whose world revolves around materialism. We have people whose world revolves around having a kind of a philosophic base that they get their meaning from a group. We have people who begin to see the value of an individual, kind of spiral dynamics, Graves theory, all of that. And if you come at that person with the wrong story, if you try to tell someone who values the uniqueness of each individual, and you tell them the reason to do this is you'll be healthy and well and you'll be able to make a lot of money at work and you'll have lots of toys, that's not going to be very appealing to them. But if you tell them, you'll be healthy and well and able to make social change, that may be very important to them. But you can't know that until you've listened. And part of it is listening in a way that defines their story. So I think the first part of functional medicine, integrative medicine, is to recognize that it's a whole person sitting in front of you. And then I think what sets, functional medicine apart from integrative medicine is the focus upon understanding why things happen. Functional medicine is not simply green pharmacy. It's not making a diagnosis in the traditional way and then saying, okay, what's my substitution?
Yeah.
It's not following an illness script.
Red yeast rice for a statin. That's
right,
an example.
Exactly. Yeah. It is instead saying, what is the underlying process that's driving this? As we talk about hypertension as being essential or primary, but a significant number of people who have hypertension have an underlying cause for it. Yes. It may be hyperinsulinemia, having high insulin levels, that earliest stage of, not tolerating sugar well, or oxidative stress contributing to the hyperinsulinemia. Or it may be heavy metal toxicity, toxic elements, whatever it may be. When you look at it, it's not a simple matter that I'm going to give you something like a medication to improve it, like an ACE inhibitor, and I'm not going to give you instead a green choice like bonitopeptide from fish, which is also an ACE inhibitor to deal with the issue. It's better to look upstream, and that's what sets functional medicine apart. And a certain pundit recently went off about what functional medicine was, and that it, was a profession that trained everybody, right? And that it wasn't academic. Well, this is academic. It's looking for root cause. And more importantly than that, when it comes to talking about making meaningful changes in people's lives, because functional medicine isn't just about the disease process. We recognize very strongly that wellness is more than the simple absence of disease. So the goal is not just to get people back to no symptoms, or no symptoms that qualify for an ICD-10 or an ICD-11 diagnosis. Instead, it's to get people to optimal wellness. And to do that, where they need more than just the practitioner in the office to do it. The Mark Hyman, Mehmet Oz, Daniel Amen program at Saddleback Church with the minister there, whose name I'm frankly blanking on at the moment. But, they trained the trainers. It was a church in Southern California. They had a very extensive community-focused education program and connection in small groups. So they trained the trainers about healthy living. And then the trainers trained their group members, and it made change. If functional medicine trains professionals slightly outside the box, but they become people who can engage in wellness, then it makes a big difference. And, that's what the Consilience Partnership did when we went to Feathered Pipe Ranch and taught there. It was 5 days to optimal wellness, and it was about a self-discovery of what our individual stories were. And then it was, hey, an understanding of functional medicine, even for the layperson, can be the filter by which they decide what to listen to.
Yeah, I love that. So it's really about trying to understand, you said a couple times in 3 different ways, I think, the why, right?
Yeah.
Why is XYZ happening in the body? And oftentimes in cardiometabolics, they are related, right? There's multiple reactions to a root cause. 2, you said knowing that whole story. You have to listen, right? You have to hear somebody. What are their motivations? What are their interests? What do they care about? And how can we support them in those goals? Which makes me think about something else in terms of, we all have our own journey, and sometimes we don't understand exactly how to get there. And so us as functional medicine providers are really guides in that. And so your leadership and really how you've brought groups together and having it a community-focused, multifactorial, comprehensive approach is one of the ways that differentiates functional medicine and is academic in essence,
Right.
even if it's not strictly only taught in medical school, right? It's a multifactorial approach, nutrition being a classic example. I'd love to understand a little bit about kind of the nuance and how you assess patients who come in with some of these common, again, cardiometabolic, cardiovascular concerns. You brought up hypertension.
Right.
Talk to us about what you look at. What type of biomarkers are you interested in seeing? What type of questions should patients, if they're listening to this and they have been diagnosed with hypertension, what should they be asking themselves or their doctors? Give us a smattering of that.
I think the first and most important thing that patients should be asking is, what does my blood pressure do when I'm not sitting in the doctor's office? Because, the classic way in research studies is to have someone sit down for 5 minutes, take their vital signs. You let them sit for like another 5 minutes, you take their vital signs, and you let them sit for another 5 minutes and you take their vital signs, and then you average them, right? So you average out the blood pressure. Well, that's a blood pressure at rest in the best of conditions. And in a busy practitioner's office, if your first blood pressure is high, the response is, oh, that's white coat hypertension. You're nervous about being in the office. Well, I don't think I'm that scary, and I don't think that you're that scary to really drive someone's blood pressure through the ceiling, right? And if they're doing it in the office, then they're probably doing it elsewhere, which is why Joint National Commission 8 really moved away from being able to say, hey, it's appropriate to tell someone that they have white coat hypertension. You want to know what they're doing. Mm-hmm. And the second piece is, so getting some idea beyond that setting, what your blood pressure is. And part of that is like paying attention to how you recover from your exercise, like maybe what your blood pressure is at peak exercise, but also during your recovery. And one of the things that we should all know is that the pulse pressure, the difference between the systolic and diastolic blood pressure widens with exercise. So theoretically, with exercise, your diastolic blood pressure should drop as your systolic goes up. And if your diastolic is actually going up as your systolic is going up faster, that's suggestive of endothelial dysfunction.
Which is an easy thing for people to typically measure outside of the office.
Yeah, exactly. They can do it at home themselves, take their blood pressure before exercise, at peak exercise, and then a couple times during recovery. And it's something to talk about with physicians about. The other big piece is just simply recognizing that 120/80 is no longer a normal blood pressure. Indeed, a systolic blood pressure top number between 120 to 130 is actually considered elevated blood pressure. And any reading above 80 is considered hypertension. stage 1, but it is indeed a diagnosis. So as a starting point, just getting good vital signs and having a conversation about what the numbers are like at home becomes important. And then moving on from there, right? Looking for, taking a good history, seeing, is there a reason to suspect this person has a toxic element exposure? And digging deeper if there's the least bit of history.
Toxic elements such as just
heavy metals
heavy
like
metals.
mercury, cadmium, lead, and digging a little deeper, right? I had a patient when I was running the Functional Medicine Research Center's clinical kind of intramural research program. And we were following this woman after a clinical trial, and her blood pressure, which initially improved with like lifestyle, didn't improve to where we wanted it to be, even though, we had made significant changes in terms of body habitus and all of that, lost weight, BMI had gone from obese to, overweight, waist circumference had gone down, all of those sorts of things. And she worked here in Tacoma, and she worked up the hill from Ruston Way. And she was like, well, I don't think it would be a problem with, heavy metals, because they actually dug out the soil all the way around the nursing home where I worked to a depth of 6 feet about 10 years ago, because it was contaminated soil and it shouldn't still be an issue. But at that point in time, and this goes back like 15 years, at that point in time, the winds were still blowing the dust off the super site that was the old Anasarca refinery there, and blowing the wind up the hill. So even though they had replaced the soil, she was still being exposed. And, on both her spot and provoked urine for toxic elements, heavy metals, she was positive. So she had an ongoing exposure as well as having a burden.
I want to come back to this heavy metals conversation because I think it's really relevant to cardiovascular disease in general.
Right.
And I want to talk about more of the differences in assessment. A lot of people screen in blood versus urine. But I want to just emphasize, so doing a comprehensive look using labs that go beyond just an acceptance of you have high blood pressure, I'm just going to put you on a medication, was your first step.
Well, the first step was taking a history. And seeing that there was a reason to suspect, because we can't do the broad testing on everybody.
Sure.
But we can do things like making sure magnesium levels are good. We can do things like doing an advanced lipid panel. The gold standard is probably the 2-hour glucose tolerance test if you're looking for signs of insulin resistance. But doing a 2-hour glucose tolerance test is a lot to ask of a patient, and it's also a lot to ask of a physician's office. And you can get a lot of value out of doing a fasting glucose and a fasting insulin, because you can calculate a HOMA score, HOMA-IR, homeostatic model of assessment for insulin resistance. And it's very simple. If you're using American units, it's just blood sugar times insulin divided by 405. And a value less than 2.
Did you get that, everybody? Say it one more time, Joe, just for people who are interested.
Glucose times insulin divided by 405 if you're using the standard units that we use in this country. If you're using Canadian units or European units, I think the correction fraction's 22.5. But the point being that if you have a score less than 1, it's ideal. Less than 2, there's a very low likelihood of insulin resistance. And greater than 3, you're moving into the insulin resistance area. And between 2 to 3 is that kind of equivocal piece. And what it basically is saying is that in order to maintain an effective blood sugar, your insulin level is higher in order to keep your blood sugar low. But In the earliest stages of insulin resistance, the blood sugar, which we typically look at, or even the hemoglobin A1C, which we look at, won't have begun to budge yet, but the insulin level will be higher. And, and considering that, an insulin level in some labs of up to 18 is considered normal, and a blood sugar of up to 100 is considered normal. 18 times 100 is 1800 divided by 405. You actually have a score of 4.5. So you could be told, hey, you have a normal insulin and you have a normal blood sugar. They're a little at the top end, but you actually have begun that progression of high insulin levels followed by high postprandial or post-meal blood sugar levels, which a hemoglobin A1C will help to catch. And then finally, you'll have that elevation of fasting blood sugar and making a definition of diabetes if it's over 125. So that's an important part. There are numerous tests that can be done to look at endothelial function. The EndoPAT by the Israeli company Itamar that measures it is a really nice way of looking. Does if you've cut off the blood supply to an artery, when you release it, does the shear stress, the increased flow down the artery, lead to the production of nitric oxide and dilation of the artery, a healthy response?
Could you describe, just for those who are unfamiliar with this testing, because I think it's a really cool assessment procedure, right. Could you just describe what's involved?
Yeah, it basically, little balloon-like devices. It looks a lot like an oxygen sat, right? An oximeter is put on your fingers, right? And on one arm, you get a blood pressure cuff put on. And the blood pressure cuff is blown up high enough to cut off blood flow to the arm, and for 5 minutes. So to be fair, it's like having an arm that's asleep. Your arm goes to sleep at night and it's tingly when it releases. I've only had one patient, and I won't say who it was, but it was a colleague of ours. I've only had one person refuse to ever have the test done a second time. But indeed, when the blood is released, when the blood pressure cuff's released very quickly, blood surges down and you can see that there's increased flow, and you're measuring the flow through the two little finger devices. So you're measuring the baseline unchallenged in one finger, and you're measuring the challenged in the other, and you should see a prompt response. And if there's not, there's something interfering with endothelial function.
And endothelial dysfunction defined. I like to make sure that we have all the terms defined here.
The lining of the blood vessel is called the endothelium. And the endothelium responds to blood flow, the stress of blood flowing down, by dilating. And this is the way our system, responds to, oh, well, my legs need more of a blood supply because I'm running. Or, oh, my gut needs more of a blood supply because I'm digesting dinner, right? And we kind of partition where we're sending our blood. And as increased demand takes place, flow increases. And if it's a healthy vessel, it's going to dilate, allowing for more filling. And it does that by the production of nitric oxide. But high insulin levels, higher amounts of excitation, and kind of an imbalance between calcium and magnesium, toxic elements, problems with methylation, because the same enzyme that makes nitric oxide, if there's not enough methyl groups, like if your homocysteine level's high or you have a problem with MTHFR, makes peroxynitrate instead, and it's oxidative stress as opposed to production of nitric oxide. So all of these things lead the blood vessel to not relax.
And this is important for people not just to run a test, but we're thinking about stroke prevention. We're thinking about prevention of a heart attack. We're thinking about just being able to have good blood flow to the brain, to be able to think clearly, to age well, to have good perfusion in your skin, all the things. This core concept that you're talking about, but it shows up the most when we're thinking about dysfunction in a cardiovascular or cardiometabolic context, because typically that's when we see symptoms, right? Is later on.
And you want to kind of find this dysfunction early and to understand kind of the underpinnings of how hypertension is related to atherosclerosis or the laying down of cholesterol and the development of plaques. If you think about that endothelial layer, it's one cell layer thick. And either at junctions, where there's a fork in the road or things are coming together, there can be turbulent flow, or in a blood vessel that doesn't dilate because there's endothelial dysfunction. With the surges, there can be little micro tears that take place in the vessel wall. And interestingly, this leads back full circle to that kind of concept of no white coat hypertension, right? Because when you think about it, it's a little bit, to make an analogy that I use a lot, or I always get confused about analogy and metaphor. But anyway, a story that I tell my patients a lot is like when I was growing up on the East Coast, you could go to the beach all summer long, and the beach at Rehoboth may be 200 yards wide. And then you'd get a summer hurricane come through. And if it particularly hit that area, the beach got truncated. You lost all the beach due to the storm surge. It's not the day in, day out beating of the waves on the beach that affects the beach. It's the storm surge. In our blood vessels, it's the same thing. It's not, that my normal blood pressure is good 85% of the time. It's that 10 to 15% of the time where I'm doing something that causes my blood pressure to surge and creates those micro tears, because those micro tears allow for the deposition of cholesterol and also allow for the transmigration or the movement of a certain type of white blood cell called a monocyte into the vessel wall, where they become activated macrophages, which are there to clean up the mess. I mean, the intent's to do good things, but they are so overwhelmed in that setting potentially that they pick it up until they are full of cholesterol and fat, and then they look like a foam cell. And they keep growing in size until they either sort of die or become quiescent, and they become the foundation of a plaque.
Mm-hmm. And that's the beginning of atherosclerosis. That's right. The definition of that. And so one of the origins that we just discussed is insulin resistance can lead to hypertension. Hypertension, even if it's in range 85% of the time, but out of range 15% of the time due to whatever the cause is. If you're not able to appropriately dilate the blood vessel, then we can have these micro tears occur and the pathology that you just described. And this is, I think, really relevant for people to understand that this is what happens not just over a day or a week. Right. This is years to decades that causes this. And this is what we want to catch early. And that brings me to kind of the next area I wanted to discuss, which is advanced lipid stratification and testing, right. And then also screening imaging. So specifically carotid ultrasound, coronary calcium score, and even coronary angiogram for asymptomatic individuals. Right. So I'd love to hear your thoughts on kind of that next line of assessment.
Yeah. So one quick thing, insulin also contributes to atherosclerosis by being such a driver of inflammation. And we're not going to get to treatment, but it's very interesting that AMPK agonists, a certain kinase, the drug in that category is metformin. Berberine is a green alternative in that case. But backing up and saying, let's address, those individual pillars of inflammation, energy, metabolism, and stress responses, which are all interconnected because they really all are, right? But to move to your topic, there's a lot of attention these days to the advanced lipid panel. And in some ways, the kind of advanced evaluation of a patient for, coronary artery disease is healthcare for the elite at this point in time. I hate to say it. And we aren't necessarily using our testing in a way that's very respectful of our healthcare dollar. I mean, there's a lot more information to be gained when you do an advanced panel than a standard panel. But the reality of it is, in a world where 50% of us are expected to be obese by 2030, if you have an abnormal standard lipid panel with a high LDL, it is an indication to start making lifestyle changes. But if you want to understand it more deeply, then it is appropriate to go further. Or if you're trying to make a decision about whether one of the cholesterol lowering drugs, the HMG-CoA reductases that we call the statins, if we're trying to make a decision about their use, then maybe we want to know a little bit more information. So one of the things to say about the way that we've always explained a lipid panel to people is we've talked about good and bad cholesterol. Yeah. Well, there is no such thing. Sure. All cholesterol is the same. You know that, I know that, most practitioners know that. But when we talk to patients, particularly those of us who have to do it quick, oh, you have a good cholesterol and you have, so bad cholesterol, you're okay. And that ends the discussion. Or your bad cholesterol is high and let's put you on a statin, and it ends the conversation. But the reality of it is that when you look at that panel, what you're really asking the question about is how do the carrier proteins called lipoproteins function and transport cholesterol, right? And LDL has a very important job in its cousins, right? The VLDL and the IDL and the triglycerides. Basically, they're the delivery system. They're taking cholesterol out to the body to be used. And we need cholesterol because we turn cholesterol into vitamin D. We turn cholesterol into the sex hormones. We turn cholesterol into cortisol. We use it for cell membranes. We use it for neural tissue. We need cholesterol. We can't ignore that fact. But LDL is the lazy delivery guy. And at the end of the day, it's like the cement truck driver who's on this side of the Narrows Bridge with half a truckload of cement. He's 10 minutes from home and the quarry's on the other side of the bridge an hour away. He finds someone's drainage ditch on the way home and leaves them a little cement problem, or in the case of an LDL, a little cholesterol problem. HDL has a different function. HDL's primary function is reverse cholesterol transport, picking up that cholesterol that hasn't been used, taking it back to the liver to be recycled. And some of it, to be fair, is, as LDL circulates around, it can stop off at the liver if there's enough LDL receptors. And if the LDL receptors are being inappropriately degraded, then there's no place for the LDL to dock and it just drops it wherever. But that's the basic problem, right? The LDL leaves cholesterol, low density lipoprotein leaves cholesterol where we don't want it to be. And HDL, which is tasked at picking it up, may not be doing such a good job of picking it up.
As we once thought. Once thought there was some hope that high HDLs had, promise if you could develop a drug that you could raise your HDLs, and those trials did not turn out to be as fruitful in terms of prevention.
Right. But they also probably weren't reaching goals in quite the right way, because they were raising HDL, but they may not have been increasing the function of HDL. Because when you talk about particularly the HDL molecule, it's not just transport. It has anti-infective properties. It has antioxidative stress properties. It has to be functional. The analogy I make to patients about that is, if I happen to be the mayor of a small town and we're having a snowstorm, and I call up my city manager and say, hey, how many snow plows did we get out on the road? And he tells me, well, we put snow plows on 48 of our trucks and they're out on the road. As the mayor, I could say a good job, hang up the phone, and he could turn and look at the head mechanic and say, thank God I didn't have to tell him that 46 of them were broken down by the side of the road, right? If HDL isn't working, then that's important to know, right? And that's can be part of what we measure. Like a myeloperoxidase gives you
another lab test that is often
right,
included in an advanced lipid
panel, gives you an idea that your HDL is functional. Cleveland Heart Lab has a specific panel for looking at HDL functionality. So in the day that we looked particularly at women, in their 40s, 50s, 60s, and 70s, and said, oh, you've got an HDL of 80 or 90, yeah, your LDL is 140, you're okay, because we thought the ratio was good. We now need to make sure that that woman's not in the trap of having dysfunctional HDL. So that's the important part. And when we're looking at this, it's the small, dense LDL particles and the ones that get modified, either oxidized or glycated. Oxidized means having an oxygen added to them. A non-scientist would call oxidation like rust, but we'd also call it rancidity, right? If you leave olive oil on the kitchen counter in the sunlight, it is going to go rancid, right? And that's what happens to our cholesterol. If it's exposed essentially to extra oxygen and exposed to inflammatory stresses, it's oxidized. Glycated means that it has sugar attached to it, just like hemoglobin A1C is a glycated hemoglobin molecule. We can't measure glycated LDL cholesterol in the reference laboratories that we all use at the moment, but we can measure an oxidized LDL. But it comes down to the advanced lipid panel. The basis of it is knowing that there is the particle size and particle number. And people, and to be frank, if you're getting
of LDLs, typically
LDLs and
HDLs.
Right. If you're getting that information, you probably don't need to know your ApoB and ApoA1, because your ApoB gives you, there's one ApoB complex in each LDL, ILDL, and VLDL. So it gives you an approximation of your particle number. So if your doctor's gotten an LDL and it's high and your ApoB's high, then you know you have a lot of small, dense particles present. But if you've gone to the level of actually measuring the particles and measuring particle size and looking at the distribution of those particles and how many of them are small, dense, you don't need the ApoB. And ApoA1 isn't quite as important, because there's not just one ApoA1 in each HDL. There can be between 3 to 5. So it gives you an idea about how many HDL particles it is, but it's not very exacting. So the standard panel that I typically get, and I like the NMR, which is a way of doing the test, nuclear magnetic resonance. I like that better than the ion mobilization if I had my druthers. But it's important not to compare the two, because they have two different reference ranges. So if you've done it one way, you should do it the same way the next time, so that you can compare if you're really interested. But a standard lipid panel, the advanced lipids, an oxidized LDL, a myeloperoxidase, and then you start digging down from there, right? You go further in terms of, well, do I want to get an LPPLA2, which can give prognostic information about the stability of a plaque? Do I want to get some of the other sort of testing, other markers for oxidative stress, for example?
And I have to say that, I use these markers to tell a story to my patient. Not to say I 100% agree with you that if I got a standard lipid panel, let's just define that for a second. It's a total cholesterol, it's an LDL cholesterol, an HDL cholesterol, and a triglyceride. If I only have those four, but I also have a HOMA score, like you described earlier, in terms of insulin resistance, I can guess probably pretty accurately that they're going to have high LDLP or they have a lot of small dense LDL particles. I have a pretty good idea just with that information. However, I like the information, which I agree is more of a privileged way of practicing medicine because I can order some of these more advanced panels. But I describe it to patients so that they hear it three different ways. Well, your LDLP is high here because I'm seeing your insulin resistance is elevated, and that then creates this elevated triglyceride to HDL ratio, which these are the markers we're looking to get lower. And people, I'm sure you've seen this a million times, they want that information. It motivates them, right?
It's a lot of, well, we learned this during Lifehouse. You and I participated in the Lifehouse trial. People a lot of time are interested in information, and for a group of people, that actually changes behavior. But it's our job to make sure that they hear what they need to hear to change behavior, because a lot of times it's fascinating to get information and it doesn't cost them much other than the cost of the test. But making the lifestyle change and staying in the pursuit is important. Where I find the advanced lipid panels really good is when you have to make a treatment decision, right? My mom's 91. She just had some shortness of breath. She had a fall last year. She stopped walking her 3 miles a day because she had a broken elbow and she broke her foot at the same time, and less exercise, some shortness of breath, and evaluation for that, right? And she had pretty normal all the way around cardiac picture, right? But she had a coronary artery calcium score in the 120s. At 91 years old,
pretty darn
her
good.
cardiologist wanted to put her on 80 milligrams of Lipitor because of the change. Her LDL cholesterol prior to any sort of treatment for cholesterol was 72. She had an oxidized LDL of 36. Now, that may be partly...
Let's just pause here for those who don't know. Goal typically is to try to get somebody below a 70 of LDL cholesterol. Right. And your 91-year-old mother was at 72 prior to any treatment. So just to emphasize,
she was at goal
the
for
significance.
Treating.
Exactly.
Right. And they wanted to put her on a statin drug with potential issues, right? And, we don't have the time to talk about statins necessarily. But the point being that having that additional information, knowing that her small dense LDL was very low, knowing that her oxidized LDL, which is ideal if it's below 60, using Quest and Cleveland Heart Lab, hers was 36, right? So it's like, cool, that's a great place to be. She doesn't need that drug. And that's where it becomes helpful when you're trying to stratify people's risk.
Yeah, and I would underscore, for a 91-year-old woman, that makes a lot of sense. If we're talking about a coronary calcium score in a 45-year-old woman of 120, even with very good cholesterol, it's a different conversation.
Yes.
And typically, that's one of the things that we have to think about. What are these other causes that are allowing that amount of LDL cholesterol to cause a plaque that early?
Yeah. Right. Or what other physiologies are taking place? Insulin resistance or toxic elements or autoimmune conditions.
Exactly.
Because, when you look at it, the interesting thing about addressing lifestyle issues, if I treat someone in their 20s, 30s, or a woman in their 40s, not so much a man, because without the estrogen, men by their 40s should be more considered middle age. But if I address someone in the early portion of their lives and address the cardiometabolic issues, I may be gaining them decades. If I move into that 40 and 50-year-old, I'm gaining them years to decades. If I move to the 60 to 70-year-old, I'm gaining them years. If I'm talking about a 91-year-old and I treat their higher cholesterol, assuming that my mother had a higher cholesterol, but I treat that degree of atherosclerosis in a 91-year-old, I may only be gaining her months.
With potential consequences.
And her biggest fear is cognition, right? And there are the studies about statins that suggest a potential compromise of that. So, we made a choice. But, we brought up the coronary artery calcium score, and it's one of the tests that we do because, when you're looking at cholesterol treatment and you're considering a statin drug, if you're looking at it sort of from a functional medicine, integrative medicine perspective, you make a differentiation between primary prevention and secondary prevention. Primary prevention means preventing the first heart attack, first stroke, first episode of sudden death, first need for revascularization, right? Or first hospitalization for chest pain. Those are all clinical findings because in the past, those were the only endpoints we could look at. We didn't have an easy way, short of doing a cardiac catheterization, which involved putting a catheter into the artery in your groin or at your wrist and, snaking a catheter up and squirting dye in to get a picture. We didn't have a good way of doing that. But, with the coronary artery calcium score, we got an easy way of doing it. But, primary prevention, preventing the first episode versus secondary, preventing the second. Statins are really quite good for the second, and they should be strongly considered for the second. But for the first, it becomes more of a nuanced discussion. But the utility of a coronary artery calcium score, as you point out, is to see what the burden is of calcified plaque, right? You're not looking at soft plaque, you're looking at calcified plaque, which means that that plaque has already undergone changes and cells have died and cells have become necrotic and calcium's been deposited. And it's a relatively hard plaque, which may actually be more likely to crack when you get some of that shear stress. But you can use that coronary artery calcium score as a surrogate for saying, okay, maybe I don't need to wait for the first event. If I have a really high coronary artery calcium score, that's kind of the equivalent of having known coronary artery disease. And you pointed out very wisely early that you don't wake up one morning having a heart attack and get the diagnosis of coronary artery disease. You've had atherosclerosis and all the precursors for decades.
And one important piece that I think you just described is this concept of stable plaque, right? Or calcified plaque. It's not per se stable in the sense that it's not dangerous. It still has danger, but we think of it as potentially less mobile or less turbulent than soft plaque can be because it hasn't yet gotten that crust over it and can certainly be knocked off and causing a blood clot further down the line.
Right. I mean, in many ways, a vulnerable plaque is a little bit like a pimple. We've all had an experience with a pimple or an abscess, right? It comes up, it starts getting inflamed, you see some redness, you see some changes, some heat on your skin, and then a little whitehead develops, and then suddenly you see pus. And that will typically progress, like in an abscess or whatever, that'll typically progress to a rupture, and that pus comes out. Well, when that pus is thrown out of a soft plaque into the blood vessel, the lumen of the blood vessel where blood flow is flowing, it's highly inflammatory, and it's thrombotic, meaning it's going to promote clotting. And when it does, you can go from having a soft plaque, which maybe led to a 30 or 40% reduction in how much blood flow could go through, to suddenly having clot formation. And now you have a 95% or a 99% or a 100% obstruction of flow. And if you get 100%, you've got a total occlusion. And, that's why, anti-clot medicines, including like taking an aspirin, are such an important piece, because an aspirin keeps the platelets from clumping up together, because the platelets all glomming on, right? That's the first step to forming that clot.
Mm-hmm. And that's a really important piece for people to understand, is that there are multiple steps involved in how this process happens. Right. And ultimately, the reduction in cholesterol is just one piece of the puzzle. It's not just about statin therapy. It's about good blood sugar control. It's about reduction of inflammation. It's about reduction of any toxic elements, as you described a few different times, management of healthy blood pressure and healthy dilatation in the blood vessels. It's all of it.
Right. Even homocysteine.
Homocysteine.
It is recognized that homocysteine is an elevated homocysteine is a risk factor for coronary artery disease. But it is not well recognized that lowering homocysteine is going to make a difference in terms of your outcome. But the studies that were done didn't even get in the treatment group, didn't even have the goal of getting the homocysteine to the normal range, much less an optimal range. The optimal range, most people would agree, would be less than 8, mm-hmm. right? Mm-hmm. And normals for a good number of years were put in the 12 to 14 category, and now people are going up as high as, 11 to 12, and now people are going as high as 15, mm-hmm. right? But, if you took people who were 18 to 19 and reduced them to 14 or 13, and compared them to people who weren't treated, there wasn't that much difference, right? In terms of how much of a difference you made in terms of lowering it. And the other important part, the studies were relatively short. So for something that's contributing to the development of a plaque, which may be years in the making, mm-hmm. before something happens, and that something can even be stress, mm-hmm. when it comes to something like Absolutely. Broken heart syndrome.
Yeah.
People can have almost clean coronaries and have a heart attack because of stress or trauma, something that breaks their heart from an emotional perspective.
Unfortunately, known several cases of that. And it's amazing how that can overtake somebody and cause such a massive event in the physical realm. I feel like we could talk for 3 hours about right. this easily. I do have a kind of final question for you. If we shifted cardiology from rescue medicine to preventative medicine, what do you think would change most? If the system were to make a change, what would that change be?
Well, I think we talked about it earlier. It's accepting that wellness is more than the simple absence of disease, and having people spend the time to know why they want wellness. A lot's been written that motivation doesn't work, right? BJ Fogg's whole thing is simple little tasks, tie them to something that someone's already doing, and you crowd out bad behaviors. But the reality of it is we all know, we've all had periods in our life where we exercised more or we ate better and we felt better, and we all know that. And then life happens, right? And if we're not clear about what our purpose is, and even when we are, it's easy to get sucked back in. Like, I'm flying to LA 3 days a week now since September, right? I've been doing it for 2+ months. It's taking a toll on my lifestyle in terms of my exercise and my diet, right? I know better, but I'm still flying and working that way. And when people's stress happens, or, a partner loses their job and only one income for the family, or there's illness or whatever. I mean, I think the key is going to be to help people recognize their uniqueness, that they are actually very special. And they're really the only person who can do what they were called to do on the planet at this point in time. And we all need to accept that responsibility. And accepting that, when people start realizing their value, they may take better care. And the system has to help them. And that's why, we wrote the paper that was called Our Healing Journey as well, because it's all about that, sacredness needs to return to the exam room setting and to every encounter, right? We need to remember our place in the world. We need to remember our relationship to other people. And we need to remember what's important. And when we do those things, a lot of the lifestyle changes will take place. And then we'll be on our way to making the lifestyle changes that prevent the end expression of diabetes or end-stage kidney disease or atherosclerosis.
Having your own mission statement, having your purpose-driven, kind of
Right.
soul-driven mission behind what you do, why you do it, is a big component.
Right.
It was beautiful.
And recognizing it in someone else, right? If I can see that there's some spark within me, some people may call that spirit, some may call it, to use Star Wars terms, the Force or whatever it may be, creator, blah, 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 that there's something in me that makes me special. If I can recognize that, well, I am obligated to recognize it in everybody else, right? And if I can see it in you, the next step is to realize that I owe you service as well. I owe you community. I owe you relationship. I have a responsibility, and we have that same responsibility, not just to the humans on this planet, but we have that responsibility to the more than human world, or
The dogs.
We're not going to leave much. The dogs and everything else, right? If we don't take care of this planet, we're not going to have much to leave to our children or grandchildren.
Oh man, that's a whole other conversation. Thank you
Yes.
for saying that. Well, it's been such a pleasure chatting with you. Thank you
It's
for
been wonderful. Thank you, Michelle.
coming here today. And this has been another episode of the Vida Vitality podcast. You can find us on Facebook, Instagram, and at thinkvita.com. Thank you.